I'm going to start with a case that's unusual that I was involved in August when I was doing AIDS consult in the hospital. Sousa Coffey saw this patient and then briefly, and then it was the end of her 2 weeks, and then I took over. Challenging. Okay, so this is a 54-year-old HIV positive man who was in care at South of Market and suppressed and doing very well until 2011, when he just completely stopped all engagement in medical care. 3 years later, he was at St. Francis with cough and dyspnea. His chest film showed a right lower lobe infiltrate. He was given azithromycin, and he got a lot worse overnight and came back and had a severe headache, and he was more hypoxic. I don't have those numbers. He was given some IV antibiotics and transferred to San Francisco General. His past history is that he was HIV positive first in '93, right after he had immigrated from Mexico to this country. In 2003, he had rifampin-resistant miliary TB that was treated. He somewhere had gotten a viral load in October of 2013 that was 360,000. And his viral load was checked at St. Francis. I mean, the CD4 count was checked at St. Francis, and it was 3. He also had a history of a pan-sensitive genotype or around the time he stopped taking ART. He was housed and actually had a job in a medical clinic, although what medical clinic was very vague. He had a remote history of injection drug use. And on review of systems, he sort of consistently at both hospitals complained of decreased vision in his right eye. So, on admission here, San Francisco General, he was a febrile, more or less normotensive, not tachycardic, not tachypnic, but hypoxic. Hypoxic even on 2 liters of oxygen, nasal oxygen. He looked chronically ill. He had thrush. He had a pretty unremarkable exam other than that. And he was oriented, but very, very weak. He couldn't move. He couldn't walk. His initial labs, he was anemic, he had normal white count and platelets. His chem panel was okay. His lactate was 2.3, which is elevated. He had a transaminitis with AST and an elevated LDH and a kind of non-specific but abnormal UA. So we have with us today our HIV pulmonary expert who agreed to tell us what we are seeing here. This was his admission x-ray at San Francisco General. Thanks, Andy. There are actually a couple of slides that this will help with. Lawrence?
You probably don't need a pulmonologist to tell you the x-ray is not normal. So this is a frontal projection of the individual. He has bilateral radiographic abnormalities. So the first thing, is it abnormal or normal? It's abnormal, and then where the abnormalities are. So the abnormalities are bilateral. So you've got a PA and lateral. So they're bilateral abnormalities. The abnormalities are predominantly in the middle to bottom half of the x-ray. So if you just look on top versus in the bottom, the abnormalities are more towards the bottom than the top. And then probably more on the left side of the film, which is the right lung, compared to the right side of the film, or the left lung. So bilateral, predominantly middle and lower lung zone abnormalities, maybe right greater than left. And then the last thing you describe is what you're actually seeing. So these are probably what I would call like granular opacities. It's not necessarily a focal consolidation, like an alveolar filling process, but they're sort of granular opacities. Again, mostly towards the right. You can see right adjacent to the right heart border, there's this sort of confluence of the opacities. And then you get a little bit of a sense that there are some more nodular opacities, and maybe you can sort of see it in the right lower lobe. There's a more dense area, and so whether this is just a lot of the abnormalities coalescing in this area, or whether this represents a distinct nodule. If you actually look in the upper lung zones, which are less involved and therefore maybe easier to see other abnormalities, you do get a sense that there are several small little dots and nodules. And so those could potentially be vessels, but some of them seem a little too far out to be vessels on end, so you wonder whether it also has some nodular opacities. And then I guess the last sort of thing that caught my eye, which is a little bit hard to say for sure, and maybe I'll look at the lateral in a second, is on this side here you see the left costophrenic angle is very sharp, it sort of has the normal contour. On the right side, it's sort of sharp, but you kind of expect it to go down a little bit deeper. And so one of the tricks is you see the rib right here, so you can't tell whether this is the rib that's blocking this, but I think probably this area should be clear, because this is not where the rib is, and so you wonder whether there's some pleural thickening or pleural effusion, or I guess in theory, pneumonia or atelectasis that happens to be in the costophrenic angle. And then when you look at the lateral again, you see posteriorly the angles are pretty sharp, sort of have the right appearance. And then anteriorly, you get a sense that maybe there's something here that wouldn't be a rib, but that would be pleural thickening or pleural fluid.
Thank you. Any cysts you see in there? Like on the frontal projection? Like down on the right lower and then the right upper as well?
So cysts are very hard to tell on chest X-ray. You can often get a sense of them, but to strictly say that you're seeing cystic lesions, you need to be able to trace the thing circumferentially, 360 degrees. So if you only see certain parts of it, like, well, I see something here, or I kind of lose it here, you can't really call it a cyst, because it could easily be just a vessel or some parenchymal infiltrate or part of the lungs. But I think Mark's going to show you a CT scan in a second.
Very good question.
Okay, so let's do some differential diagnosis, some real differential diagnosis.
While we're voting, can you remind us what his T-cell count is? Just so that
It was 3 in July, 3.
3 in July, and he's off meds right now.
He's been off meds for several years, yeah.
And you would have set the stage because you're going to ask people to do number 1.
Yes, so we're going to do real differential diagnosis. So I'm going to ask you to vote for what you think is the most likely, second most likely, and third most likely, and then talk about, and then later make an empiric antibiotic choice, because that's how we do what we do. Okay, so choose. These are the things that were sort of obviously in the differential. Pneumocystis, community-acquired bacterial pneumonia. Maybe this is ARDS with sepsis, because his lactate was elevated, pulmonary TB, or something else. So vote this time for what you think is at the top of your differential and that you would absolutely for sure want to cover empirically in this hypoxic patient who's been admitted to the hospital and is very sick.
Okay. All right. I would totally agree with that. I would completely agree 100% with that assessment based on the information that we have right now. Okay. So then,
what would be your second choice? I mean, what would be second on your list of, in terms of probability? Okay, that sounds right. And third? And this decision has some major implications in terms of therapy. Okay. All right, so most people thought TB or another OI. Only 10% of people thought sepsis with ARD. Yes, even though the lactate was elevated. That's interesting. Okay. So, based on, well, this is probably a pretty simple question, but let's go ahead and vote. these are your options. I mean, I think it's pretty obvious how the majority of people will vote, but let's just follow the thread through. So some people would add amphotericin, which is interesting, but most people would do what's the logical sequela of that differential diagnosis, which is to cover pneumocystis with Trimsulfa and bacterial pneumonia with ceftriaxone. Okay. So he got a CT scan. I think it was late that night or early the next morning. Lawrence.
Again, you don't really need a pulmonologist to tell you this is not a normal CT scan. Was it a regular CT or a high-res CT? Like a volumetric? Okay.
Hey, Lawrence, before you answer that, what should we have gotten, given this situation? Should we have gotten a regular or a high res?
Probably I would have gotten neither, to be quite honest.
Because?
Because the chest X-ray is abnormal. So what you're
when
going to...
we say, hey, can you bronch this guy? What's the pulmonary
You
service
should
gonna
not,
tell?
the pulmonologist should not ask you for an HRCT. An HRCT and if you're going to get a high-res CT, you're doing that because the X-ray is normal or minimally abnormal. You're trying to convince yourself of their abnormalities, and you're looking to rule out pneumocystis pneumonia or to see ground glass that would make you highly suspicious for PCP.
On the basis of this chest X-ray, can we here at San Francisco General get a bronch without a CT?
So the technical answer should be yes. Obviously, these things are provider dependent. Those of us who are of a certain age, right, we would never have gotten an HRCT in the old days. Nowadays, we get CTs literally the same day as the chest X-ray, right? So it's a practice style issue. There's no question that CTs are more sensitive than chest X-ray, but if you're going to get a CT in somebody with HIV whose chest X-ray is normal, and if you're going to get it if it's abnormal, why get the chest X-ray?
And how are you not going to bronch this guy?
That's the question.
So
That's
we're glad
exactly
to hear
right.
you say that, because many of us, as we try to get that bronch, they say, where's the CT?
Correct. So it's a generational thing. I'll leave it at that. But people who practiced in the older days would never get a CT scan in this patient because the clinical management should be bronchoscopy, presumably after you rule out for TB, which is more of a hospital procedural issue than a clinical issue.
So yeah, it's a prevention public health issue. That is a great teaching point. Why don't you tell us what you see?
So again, I think you can hear me, right? It's not normal. The abnormalities, again, are bilateral, and the predominant abnormality by far is what radiologists and pulmonologists would call ground glass opacities. So pretty much all the sort of grayish opacities you see, those would be described as ground glass. And the definition is basically sort of these hazy opacities through which you can still see the normal vasculature. So again, if you go to an area that's a little less abnormal, it's easier to see some of the abnormalities. So this is all ground glass, and you can still see the white dots, which are the vessels. All right, so these are bilateral ground glass opacities. As the astute internist noted, the pulmonologist didn't want to say for sure on the chest X-ray, there are these rounded circular cystic lesions, and there's actually multiple ones of them. So you got bilateral ground glass, you got multiple rounded cystic lesions, and then at least on this particular cut, you again have a more confluent, sort of ill-defined nodule.
So it strikes me that, the ground glass totally fits with pneumocystis, and we know that in somebody who's not on prophylaxis or ART, there's a CD4 count of 3 for over time, that the most likely OI that person is going to get is pneumocystis. And people who've had pneumocystis for a while or who had a previous episode can have some emphysema and blebs. But it strikes me that those are sort of similar in size. I mean, that's not typical of pneumocystis blebs, is it, or is it?
Oh, this would be very classic for pneumocystis.
Okay.
The one thing that would sort of make you pause would be the sort of bigger nodule there,
Yeah.
which, again, pneumocystis can present as anything. That's not very helpful clinically. But the dominant pattern on a CT scan for pneumocystis would be ground glass opacities and then cystic lesions.
Okay, great. So he had a couple of AFB stains done on day 1 and 2 that were negative. His blood cultures were negative. So this is all becoming very tightly supportive of pneumocystis. Then he got bronch, and this is abnormal. Can you describe, or do you, or maybe you can't from this photo, but I can, if not, I can say what the pulmonologists who actually saw it in real time saw.
I'm in between bites. So maybe here you do need a pulmonologist to tell you this is not normal. I don't know how many of you have been inside the bronchoscopy suite. Wasn't quite sure, Mark, from your slide. Was it? Do you know what level this was at? Was it the level of trachea?
I'm not really sure, and you know it doesn't project all that well. But,
yeah. So there's a couple of abnormalities that I could point out. So basically, this is somewhere in the airway. I was trying to guess that this may have been the level of the trachea, and the way you know it's the trachea is that you would see a C-shaped cartilaginous ring and then a flat posterior membrane where there is no cartilage, and that would tell you that you're in the trachea, because once you pass the trachea and you're in the carina, the airways become circular cartilage. All right, so it's only in the trachea where you have a C-shaped cartilage, and then the flat posterior membrane obviously is posterior, and then below that would be the esophagus. All right, so assuming that this is the trachea, then what you can see is the major carina, if we're actually not in the trachea, because I don't have enough of this view here, sort of more proximal, to see whether this is C-shaped or not. Normally the carina are the branch points. For those of you who are not physicians, they're branch points of airways, and normally they're sharp and they're sort of uniform, and I don't know if this is the abnormality you wanted me to get at, but up here, it's really raggedy, it's not sharp. This would be a little bit more sharp, and then also over here, it's kind of lumpy bumpy, and then maybe this area here would be more quote-unquote normal. So you don't see pus, I don't see chaos lesions, but interestingly there's these kind of very irregular areas that seem like they're concentrated at the carina, the branch points of airways.
So the report was that there were these kind of plaque-like lesions that were diffuse in the airways. And that is definitely not something that one would expect to see with pneumocystis pneumonia. Correct. And then stuff started happening very quickly. The initial stain on the bronchoalveolar lavage fluid was positive for encapsulated yeast. The pneumocystis stain was negative. An hour later, there was a call from St. Francis that a blood culture that had been obtained maybe 2 days before was growing moderate round yeast, and somebody had thought to order a serum cryptococcal antigen when this guy was admitted, maybe because of the headache or just because we should do that on a serum crag on everybody who has a very low CD4 count, who is admitted, who is sick, quite frankly. And that was positive. On the other hand, his mental status was intact. He didn't have any deficits. So the trimsulfa was dropped and amphotericin flucytosine was added. That was a long day. The next morning, he got tapped. He had moderate yeast that was seen on an India ink stain in the CSF. A repeat lactate was 5.6.
Did you have an opening pressure for that marker?
They were not able to get an opening pressure because he was a little agitated. So it was a difficult lumbar puncture. And they were, actually this information came back the next day, but the serum crag was 1 to 8,000 and the CSF crag was a little over 1 to 1,000. So I want to ask people just to comment on those values, whether that strikes you as middle of the road for somebody who has disseminated cryptococcal disease. Is Kat here? Because I know that we had a discussion about this. Well, what do you think, Annie?
So for people who are not on treatment, first of all, those are high. Those are not what you typically see. That 1 to 8,000 catches your eye. And my understanding is that it has prognostic value on initial diagnosis.
That's right.
But not certainly later on in time when people are
For
on
sure.
therapy. So that would make me worried. And then I also know that there's a lot of interest in sort of semi-quantitative time to positivity in the fungal cultures in terms of how quickly
Which
people
is the
clear,
second one.
but I don't know how quickly they become positive if you can draw the corollary. I don't know that data, but I know people clearing quickly bodes well, but I don't know if becoming positive quickly bodes poorly, but my gut feeling is that it's not good.
So I don't know that there is any data on time to culture positivity. I mean, we certainly know that with mycobacterial infection that a typical mycobacterial infection for slow-growing organisms like M. avium complex, the time to culture positivity has a good correlation with microbial load. And I suspect that that is the same thing is true with Cryptococcus. Most positive blood cultures for Cryptococcus turn positive at about a week or so, 5 to 7 days. This is very early. The crag titers are actually not that high. If you look at historical literature, it's probably middle of the road. So now I want to take a sidebar and talk about the lactate of 5.6. That actually was kind of an alarming finding, and that was going on, I think, the day that I came on, or a couple of days after Susan had already gone off the consult service. And we didn't have a good explanation for that. So it really made me think about lactate. Measuring lactate is something that I've come to appreciate in the last decade as an incredibly valuable tool that saves lives, for sure. And it's important to understand it and for us to be using this test appropriately in clinic with sick patients, and I'm going to get into this, but just a little background. So lactate can be elevated from overproduction, which is mostly what we think about people who've had a sepsis, a seizure, who've run an ultramarathon, who are in shock, and we've certainly saw this earlier on with some of the more toxic NRTI agents that the mitochondrial toxicity with people who have liver disease and lactic acidosis. It can also occur with underutilization when people are intoxicated with alcohol, when they have alcohol poisoning really, or have liver failure. And by unknown mechanisms, metformin can cause lactic acidosis, as can malignancy. But what's really changed in the last decade or so in the management of sepsis is the utility of measuring lactate as a marker of severe sepsis when the lactate is over 4. And the fact that there is plenty of data now that shows that the interval, the shorter the interval between making a diagnosis, a clinical diagnosis, not a microbiologic diagnosis, but a clinical diagnosis of severe sepsis, and the interval between that time point and starting antibiotics saves, the shorter it is, the better the survival is. And this is really something that impressed me a lot. When I was a fellow, my major research interest, this is a long time ago, was actually gram-negative sepsis. And I was quite familiar with all of the literature on adjunctive therapy that's been used from prednisone to monoclonal antibodies over the years. And I followed it since then, and nothing works. Nothing improves survival except early initiation of antibiotics. And this is one of the best things tools that can tell us, absolutely, we have to do this right now. This hospital has a sepsis committee that has been charged with trying to improve mortality from severe sepsis here. And they have given us a lot of feedback about specific patients that we have admitted to the hospital or who have been in our care immediately before being admitted. And they have established some standards which are really for inpatients on how to manage. They're not exactly useful in the clinic setting. So some of us have met with this committee. These people are really dedicated to saving lives. It's really this is the mission of this hospital, and they're totally into this. And they've helped us to modify the definitions and the algorithm that we use in a way. It's been an iterative process. This has gone on for a couple of years. There have been a couple of cases that have helped us to reiterate the process. And this is now our implementation guideline and our algorithm. It's been greatly simplified. We had a previous one that really should be replaced by this on the walls, I hope soon. So there are just two things to instituting this algorithm. You have a clinical suspicion that somebody has a serious bacterial infection, which could be pneumonia, could be a urinary tract infection, could be cellulitis, endocarditis. So this is really a clinical judgment call. And there is an objective finding that is consistent with severe sepsis. And these are the ones that seem to stand up to have the best predictive power. Tachycardia with a heart rate over 120, a systolic blood pressure that's below 90, tachypnea, and that really involves counting respiration rate yourself, to be sure, in my opinion, or a fever of over 38 or hypothermia with a temp of under 35. If any one of those vital signs parameters are present in somebody who clinically you think could be sepsis, it's time to pull the trigger on instituting the algorithm, which has also become pretty simplified. We start fluids with as large a bore, IV, as we can get in, and that is really, really important. They're in the hospital, there are very, very specific guidelines about how much fluid should be given over the first 30 minutes, and we won't go into that because these people who've met these criteria are going right away to the ED. But before they go, while we're getting things ready, we have time to put in an IV, draw a blood culture, start running IV saline wide open, draw a second blood culture, and after that's been obtained, push 2 grams of IV ceftriaxone, which takes 2 minutes. And then reopen the IV and transport the patient to the ED. So that is, I think it's been a long process, but I think we're done. I think this is gonna stay as our sort of standard algorithm. And I just wanted to see if there were any questions about this. This is really important in saving lives. Any? Yeah?
How easy is it to put an 18-gauge IV?
Well, that's a good question. Is Jake here? Not so easy in a lot of our patients. I mean, it's easy to do in the ED because they have the sonographic handheld equipment that you can use to find a deep vein. It's an excellent question. So, 20, whatever. We do the best that we can. We don't have that equipment. So that's a good question. Okay. So back to the patient. I'm using this talk as a bully pulpit for 2 things, and that was one of them. Okay. So the patient was stable on day 4, and attention was turned now to this visual problem that he had. And he was stable enough at this point to go to opto clinic for a direct dilated ophthalmology exam. Now, nobody had called opto to come and do a bedside exam. Was that wrong? I mean, I didn't. I guess I could have done a question business. How many people think that he should have had just a dilated bedside eye exam done, during the first day? Okay? And how many people think that it was fine to wait until he could get a dilated exam in ophthalmology? Nobody? I do! Because you can't see very much at the bedside. And an ophthalmologist who dilates the patient isn't going to see a whole lot more than I can. Quite honestly, you can see 1/9 of the retina under optimal conditions in a black room using a direct ophthalmoscope. And there are no, you can't get complete blackness in a room. Every exam room and hospital room has windows. In ophthalmology clinic, they have a room without windows. All their exam rooms have no windows so that they can get complete darkness and dilate and then use a headlamp and a large lens to see the entire retina, including the part of the retina that's anterior to the equator. And it really doesn't make sense to do bedside exams. They really provide no information, or not useful information.
Mark, just a question about that. Given that the patient's actually got a complaint of visual loss, wouldn't the, I mean, the 1/9 of the retina that you might be able to see is actually the part that you'd be concerned about?
So it would be fine for the attending or the resident to examine, and if they saw something that was like, wow, like an eye full of blood or something, you know, to call ophtho, and yes, but to ask ophtho to leave their busy clinic to come and do a bedside exam it's not fair, it's not right. And I'm on their side on this issue. I mean, that may not be an issue in a hospital where there are only attendings, but in a teaching hospital, it really isn't right. Okay, so he did get this exam. So I would like somebody to volunteer and tell me what they see here. I hope this shows us well. Yeah. Anybody want to
Feels
volunteer?
brave. The lights are out. We don't even identify who you are. Why don't people call out things that
Speak
they see
up.
that are abnormal, if anything?
Okay, so are you thinking that like this is a cotton wool spot, these things? Yeah. Actually, they're not. They are behind the vessels, so they're actually in the choroid. But you're right, that is the major abnormality. There are these pale areas that are kind of circular that are not in the retina. If they were in the retina, they would obstruct our view of the blood vessels, and we can see them very clearly. They're in the choroid. So there are choroid lesions, and there's one little blood spot over on the far left that's a retinal lesion. So both the choroid and the retina are involved, so we call that chorioretinitis. You can, well, leave the well, all right, I've got one more to show. But so there have been rare cases of chorioretinitis caused by disseminated cryptococcal disease. It was even, this entity, clinical entity, was described before AIDS was described in people who didn't have HIV. There have been a few case reports in the literature. But actually, most visual loss that occurs in people with cryptococcal meningitis, which he has, is not caused by this. It is caused by pressure, elevated intracerebral pressure that compresses the optic nerve and can infarct it, actually. That's way, way more common than this. This is the first case I've actually ever seen here of cryptococcal chorioretinitis. So.
Mark, how sure were they? I mean, this is a guy who obviously, you know, Occam's razors out the window. How sure were they? Because a lot of times with ophthalmology, they just say, this is what it is, and that's how they do things, and that's not how we do it in medicine, but they're right, and they don't always stick a needle in someone's eye. But how sure were they that that's what this was, not something else? I mean, there's a whole variety of things that can affect the eye, PCP and toxin,
Well,
TB,
true, but this was primarily a choroiditis with really almost no retinitis. So CMV does not cause choroiditis. to my knowledge. It definitely causes retinitis. So, 95% of posterior eye disease that's opportunistic in people with AIDS is CMV. So taking that out, syphilis causes retinitis, not really. Toxo causes retinitis more than choroiditis. Pneumocystis. There were cases in the 90s, late 80s and 90s, when we were using aerosolized pentamidine to prophylax people, which did not achieve systemic levels. There were several cases, and I've seen them, and they looked exactly like this. There was no retinitis at all. It was a pure choroiditis. But he doesn't have, that seems very, very.
I guess my point is, how do we know to be done?
How do we know?
How do we know to be done and say, hey, look, he's got crypto everywhere else. This sounds like crypto in the eye. Are we done? Or does someone need to stick a needle in his eye?
No.
Is it good enough? The ophthalmologist says, this is what it looks like. Are we done? Because we're trained in these patients to be really thorough and make sure we're not missing the boat. And so can we say on the basis of this, hey, that's what this is, I'm not missing something?
Okay, why are we done? We are done. We are done because there aren't really approved, validated tests. For example, let's say we think somebody has CMV retinitis. That's purely a clinical diagnosis. Well, you could do a vitreal aspirate, and actually that's not a difficult thing to do, because if people have bad CMV retinitis, it's actually recommended that they get an intravitreal injection of ganciclovir foscarnet, and you have to aspirate vitreous before you can inject it, so you actually have it. So there's no harm. And you could send that to a lab and they can do PCR. But that's not a CLIA-approved assay. That's a research test. And its validity, its accuracy, and precision haven't been established in the clinical world. So, and I think the same thing would be true for crypto. If there was something going on in the vitreous that was an infection, like bacterial endophthalmitis, you stick a needle in, you culture it, it grows, that's solid. But these lesions are in the choroid, and to go there with a needle would permanently damage the eye. Yeah. Does that explain the thinking?
Yeah.
Okay. So this is just a picture from the literature of somebody who had chorioretinitis, and it's easier in here to see the retinitis. In the upper slide, there's an area where there's bleeding and actually some schmutz that covers the vessels below it. Okay, so next question. This is the second bully pulpit question. The primary team asked me, when should we start antiretroviral therapy? So there are a couple of options. Right away, wait, say 5 to 7 days, wait 2 weeks, wait 5 weeks. So please make a choice. Wow, cool. All over the place. I like that. All right, and so if you were to look up the CDC, NIH, IDSA guidelines for treating opportunistic infection, this is what you chose is exactly what they recommend, which is that they don't make a recommendation, and it's all over the board. So I want to read, these are the, sacred guidelines, right? Sorry. Optimal timing for initiation of ART in patients with acute cryptococcal meningitis is controversial. In patients with severe cryptococcosis, particularly those with elevated intracranial pressure, may be prudent to delay antiretroviral therapy until the first 2 weeks of treatment are done, or even longer, maybe up to 10 weeks until the consolidation before you get the maintenance part of treatment's completed. However, for patients with advanced immunosuppression with a CD4 count less than 50, earlier initiation of ART may be necessary. So there's something profoundly wrong with this guideline, which is what? Anybody want?
Same patient.
Exactly. Great, Ingrid. I mean, the people, 95% of the people who present with really severe cryptococcosis have a CD4 count less than 50. So this provides no guidance, none. All right. So some of us have, in the division, have decided that we have the things that we do in practice that are based on the literature and our experience, and we've had a lot of experience here. We're the oldest HIV clinic on the planet. So we thought we would sort of put these recommendations for management into a form that would be widely accessible to people. And Susan Coffey, who runs HIV Insight, led this effort. She recruited me to sort of on the ground get people to collaborate among our faculty and to address this specific question. I think the people that were involved were Monica, myself, Elvin, and Diane. Okay, so I'm going to take you through how we thought through this and what our recommendation is. All right, so going to data, okay, to the evidence, randomized trials that have looked at the interval between starting therapy for cryptococcal meningitis and starting ART. There aren't a lot. There are really only 3 that are relevant. There's the ACTG 5164 trial that I'm sure everybody here has heard about. But I want to just remind people of the structure of the study and then focus on the subset of people who had cryptococcal meningitis in that trial. There were 282 patients overall who all had a CD4 count less than 200, who presented with an acute OI or bacterial infection, who were randomized to start ART early or later, and the median time that people in these 2 arms started ART was 12 versus 45 days. And then we all know that there were better outcomes in the people who started therapy early. It was actually a pretty significant result given the fairly small time interval between these 2 arms. 35 of these 285 patients had cryptococcal meningitis. The trial lacked sufficient power to detect a clinical outcome that was significantly different between the 2 arms. But let's just think about what actually happened. There were 13 people who were assigned to early antiretroviral therapy within 14 days, no deaths. 1 person had a progression event subsequently. There were 22 people who were assigned to the deferred arm, 2 deaths in that arm, 1 progression. So overall, among all these people, 35 people, there were 2 deaths. Okay. There was a trial that was done in Zimbabwe that garnered a lot of attention about the dangers of early treatment. This was a study in which people with cryptococcal meningitis started ART within 72 hours or delayed it until after both induction and consolidation phases of treatment for cryptococcal meningitis were completed, which is 10 weeks. And they received fluconazole as their only therapy, no fungicidal amphotericin or flucytosine. And they also looked at 3-year mortality as the primary endpoint, which was highly significantly different, although it was a small study, favoring delayed therapy versus starting therapy within the first 72 hours. But if you look at the Kaplan-Meier curves, you can actually interpolate what mortality was at other time points. Most of the mortality was very early on. It was within the first couple of weeks, 36% in the immediate arm and 27% in the better delayed arm. And then the third trial is the co-trial, which was just published in the New England Journal maybe 6 months ago or so. This was a trial that's probably more generalizable to our situation here. It was conducted in South Africa and Uganda. There were 177 patients who all received amphotericin. They didn't get it with flucytosine, which provides synergistic fungicidal activity, but with a fungostatic drug, fluconazole, which may or may not have additive activity. But, and they were all treated for 7 to 11 days before they were randomized to start ART within a couple of days or to wait 4 weeks. So the early arm got a median 9 days of antifungal treatment, including amphotericin, for cryptococcal meningitis. Before they started ART, there were no people who got ART initiated within the first 72 hours. And that's a strength of the study, a strength. And the delayed arm was a median 36 days. And the mortality at 6 months was 45% in the early arm versus 30% in the delayed arm. This was a lead article in the New England Journal and got a lot of attention. And it was well designed. It's a big sample size. But like the Zimbabwe trial, mortality, most of the mortality was early. Just as a sidebar, the CDC, NIH, IDSA guidelines have not been modified since this trial was published. But here's what I want to point out. I made this little graph to just kind of simplify what the differences between these 3 studies are. There's the obvious difference in the drugs that were used, but except for the very, very early institution of ART in the Zimbabwe trial, there's not a huge difference between the median times that people actually did start ART, but there is a huge difference in mortality, overall mortality. So 6% of 35 people, whether they got early or delayed treatment, died in the ACTG study. In the better arms, there was, and that's at 1 year, there was 3 times that mortality at 2 weeks or 4 weeks. To us, raises the question of how generalizable are these results from the Africa studies to us when the baseline mortality is so different. So I think for perspective, it's good to look at a very large study that was done in this country involving almost 400 patients with cryptomeningitis in the pre-modern antiretroviral era, in which the overall mortality at 10 weeks was 9%. And if you interpolate mortality in the COAT and the Zimbabwe study in the better arms, it is 3 to 5 times higher. So it seemed to us, the people who were, we drew a conclusion from all that. And I'm just curious what your conclusion is now, before I tell you what ours was. So why don't you vote? And that is what we concluded, 14 days. That's right. That seems like the just common sense way to generalize this data to our situation in the United States. There are other topics that I'll get to that in a second. Let me just finish up. I can do this in 60 seconds. After the ophtho exam, the patient became agitated, but then they were able to calm him down enough to get an opening pressure on a repeat tap. It wasn't really that high. It was 24. They tapped him. They drained him to get his pressure down below 20. They retapped him a day later. He had normal pressure. Further LPs aren't indicated. That's according to guidelines. But he did very badly. He had intermittent hypotension, and his oxygen just got worse. And the thing that was really sobering was that the lactate kept climbing, and he was given bicarb infusions, and it kept climbing. And by day 9, it was 8.8. And he had also developed massive splenomegaly. And there was no other source of infection to explain this huge lactate. By day 14, it really didn't seem like he could possibly survive this. A family meeting was held, comfort care goals were instituted, and he died the next day. He had an autopsy. I pushed very hard for an autopsy because I wanted to know, why did this guy, I've never seen this kind of lactic acidosis with disseminated cryptococcus. I don't know if anybody here has. So his autopsy showed massive cryptococcal infection. And if you could turn the lights out one last time, if you start looking at every one of these little circles is a cryptococcal organism. This is his spleen. There are more cryptococci in his spleen than cells. It's pretty sobering.
And no lymphoma.
No lymphoma. No. And this splenomegaly, he did not have splenomegaly when he came in the hospital, and it happened over about a period of a week from nothing to like, down to near the iliac crest.
You never got to ART being started, right?
He died. He died the day we would have started ART. That's right. So just to come back to HIV Insight, these are a list of the topics that are currently recommended. Different people were involved in different ones. Lawrence was involved in pneumocystis. Annie was involved in several of these. We have a couple more that are coming. Paula was involved in methamphetamine. That's just about done. So check it out. It's at the upper right-hand corner of the webpage. Thank you.